Welcome, welcome. We are super excited, and it is my great pleasure to be here tonight with Dr. Selena McGee. She is one of the most requested Wu University presenters and speakers, and I am super excited to be here tonight with her. So tonight she's going to be talking about ocular surface disease. I am your host, Dr. Jennifer Stewart, and I'm really excited to be here with her tonight. So I get to, I think I've introduced you, but I can't remember. I feel like I think I introduced you last time, but Dr. Selena McGee, for those who don't know, is the founder and owner of Bespoke Vision, a boutique practice that offers patients a wide range of optometric care through its dry eye center, specialty contact lens clinic, and aesthetic suite. She's the first OD in the country to perform neurotoxin injections and laser resurfacing. She performs RF, IPL, and surgical lid procedures. She's a renowned national and international speaker and adjunct assistant professor at the Northeastern State University College of Optometry. She currently serves as president for the Intrepid Eye Society, is a trustee of the SECO board, and a board of examiners in Oklahoma. She is a fellow of the American Academy of Optometry and a diplomate of the American Board of Optometry, and is past president of the Oklahoma Association of Optometric Physicians. Welcome, Dr. McGee. This is going to be awesome.
Awesome. Thanks, Dr. Stewart. I appreciate it. So thank you guys for joining. I'm excited to be here. Make sure that as we go along, you guys ask questions. I like to keep this interactive, even though we're virtual. That doesn't mean we still can't talk to each other. So put things in the chat. I will try to get to it as we go through. I'll check it as we go, and questions and answers as well. So there's all of my financial disclosures. All of my financial relationships have been mitigated and continuing there. So we're going to talk about ocular surface disease, lids and lashes, and dry eye. One of my nearest and dearest favorite topics, because these all pull together and they all matter to each other. And so I'm excited to be here. This is my practice, Bespoke Vision. I chose that name because everything that we do is customized to our patients. And it's really important, especially if we're going to talk just for a moment about aesthetics and how that fits into your dry eye clinic along with your primary care clinic. And it does really matter how things appear and look. And, when you're in aesthetics, it's all about the looks. And so, if you've got shag carpet on the walls, if you haven't touched your website in about 15 years, you're going to have to do some groundwork before you can leap into that. But, here's my dry eye suite. Of course, this is not where I started. I've been doing this for 21 years at this point and got heavy into dry eye long ago. But this is the new building we built just 2 years ago. So let's talk about dry eye for a moment, and then we're going to jump into some questions that you guys have to answer. So I said it would be interactive. I'm going to make you guys work tonight. So when we think about ocular surface and what's happening with dry eye disease, it's when the ocular surface and the ocular structures that are supposed to protect the ocular surface fail to protect itself from desiccating stress, and then you get inflammation, and we start to go down this vicious cycle that we've all been taught. And this is the image that came from the TFOS-DUCE-2 report. And when you look on that outside circle, all of those things can cause desiccating stress. And what we're going to focus on tonight is environment. We're going to talk about topical drugs and preservatives. We're going to talk about chalasis, lid margin irregularities, blepharitis, and other things that happen with our lids, and with other things that happen that our patients are inadvertently sabotaging your best efforts. And sometimes they're even causing their own dry eye unknowingly, because the fact of the matter is patients don't know what they don't know. And we are working towards giving them the correct information in a big way. And I have some exciting news about that. But it really happens in the exam room with those personal relationships that you have with each one of your patients, and teaching them about ocular and visual hygiene. So, when should we actually test for dry eye disease? And this is important because all of these patients are sitting in our chair. We have primary care clinics. We are the primary care physicians. So when should we test for this? What should our mindset be? And my mindset has been for a very long time, that my patient has dry eye until they prove that they don't. And I think of it just like how we screen for glaucoma. We do the same thing for our dry eye clinic as well. So what are the things that you're doing to make sure that the patient doesn't have glaucoma, right? Every single patient that's there for a comprehensive exam, you're checking intraocular pressure, you're looking at optic nerve, you're doing some sort of visual field test, whether it's a fast or, confrontational field, something to look at side vision and peripheral vision. So we should be doing the same things for dry eye because it's so common. And this was a survey that was done looking at the incidence rate of dry eye. And when you look at the fact that 40% of people in their 40s have dry eye disease, that's a really big number. And it goes up per decade of life. And so when does all this really start? Well, as it turns out, that X on the far left of our screen down there on age, in those teenage years, 10 to 20, that's when we start to see meibomian gland dysfunction. And we see it more and more because of screen time, less blinking, and our worlds have changed. And so now we're seeing that happen. And then when we get into our early 30s, now we're starting to see changes in the lid margins. We're starting to have non-invasive tear breakup time changes. We get to our late 30s. Now we have tear osmolarity that's heightened. What happens in a hyperosmolar state? The corneal epithelial cells die. And now we start to see corneal and conjunctival staining. And now we become symptomatic. And there's this whole pathway. What would happen if we can prevent things in late teens, early 20s, mid to late 20s? Would we still get to this? Maybe because of hormone changes, but I think the numbers might be greatly reduced. And so that's why I'm really passionate about this, and as well as screening for your patients so that you catch patients early and educate them. Because the other part of this is patients will reset their normal. They won't tell you how they feel and that their eyes do X, Y, and Z because they just think that's how it is. And so we have to solicit good questions and look for this. One thing that's really key is looking and making sure you have a lid and lash strategy. Do you have one? And that's what we're going to talk about tonight, amongst other things. But we need one because patients ask us hard questions. Hey, doc, what should I take my makeup off with? Is it bad if I do extensions? Is it bad if I do blepharopigmentation? They ask us questions that are sometimes really difficult to answer. So we're going to try to make this as easy as possible. And one really easy way is to have patients look down so that you can evaluate the base of those lashes on the upper lid. It's really easy to see what's going on in the lower lids when they're looking straight at you, but those upper lids can hide lots of things. And so you have to have the patient look down, and then I pull their eyelid up so that I can see what's happening right there in the base of those lashes. And like this patient has Demodex blepharitis because we see those collarettes at the base of the lashes. Oftentimes you'll uncover things like extensions. If they're natural looking extensions, sometimes you won't know unless you actually pull that and look. You'll find ocular rosacea because you'll see telangiectatic vessels. Lots of things happening there on the lid that we need to look for. And it only takes a second or two to look at both of those lids. The second step that I like to do here is once I've pulled that and looked, then I really pull. And the reason I really pull is because I'm looking for floppy eyelid syndrome. And so there's other reasons to pull and tug on the lids as well, because we want to see how quickly that apposition back to the ocular to the globe actually happens. So multiple reasons. And Demodex, those little mites cause damage in lots of ways, not only mechanical damage, but they're chemical damage. They bring bacteria along with them. So these are important things. And this is just a good example of what you can miss if you just look straight on at the patient, right? And on that left picture, we're looking and we can see that there's matarosis. We can see that lashes are starting to be misdirected. So I suspect that there's Demodex, but I don't know because I really can't see. But if I just have the patient look down and pull that lid, look at all of the things that I can very clearly see. Telangiectatic vessels, all of that Demodex, because we see all of those collarettes. Collarettes are pathognomonic for Demodex. We no longer have to pull a lash and look under a microscope. It's really simple. And so that 1 second can lead you down a whole different path. So just have your patients look down. So for my gentlemen in the audience, is this how you feel when your female patients ask, hey, what should I be doing? They may not even ask. Maybe they're intimidated. Maybe you're intimidated. So I'm going to make this as simple as possible. And we're going to go over some things that I think you can use tomorrow when you get to clinic. So here's the questions that I love to ask. And this is in your handout. So some really simple things to not be intimidated by that just start a conversation. Wow, your lashes are really long. Are they natural, or do you put some kind of serum on them to make them that way? We'll talk more about that. How do you clean your extensions? That's a really easy question. If they come in with no makeup at all because they know you're going to take it off with drops and such, they may not wear it, but it's a good idea to ask the question. And especially in our preteens and our younger population, I will ask, hey, are you wearing makeup? So that I can share best practices with them while they're still very impressionable. How do you take your makeup off? That's a really important one. Do you sleep in your makeup? Because we can simply say, make sure you're not doing that. That's a really bad practice and a bad habit. And then, looking at products that we use around our eyes, they can cause a lot of problems. So would you like to know more about that? What products are you using? Those are just great questions. Do your eyelids bother you? Do you want your eyes to be more open? Simple. We'll start a conversation in a very non-aggressive way that shouldn't be intimidating for you or the patient. So I love those questions. Tuck those into your pocket. Start using those tomorrow. But here's where I wanted to get with, let's at least level set with what things are around the eyes, and then we can talk about each piece of it. So this is a mascara wand. Mascara is what you're putting on your lashes to make them darker and longer typically. So mascara can come in a variety of ways, and it can have a whole lot of bad things in it. And if they're using like a nylon fiber mascara, that actually has truly nylon fibers that can migrate into the conj. There was a big lawsuit recently where they had to extract those nylon fibers from the conj surgically. So this is mascara. I mean, you probably had patients that come in and they've had a corneal abrasion, and you can see like right where the wand, smeared across their cornea as they were driving down the road and had to swerve. I've had 1 or 2 of those patients happen. But this gentleman is mascara. So what do we see here? Let's do like a question since we're a few minutes in, and type into the chat. What's a good description? What are we looking at here? Do you want to know more? Do you want to ask a question? Type something in the chat box so that I know I'm not just staring at my little green screen. Yes, lash extensions. So you guys are so right. Red eye. Yes. We got inflammation there, right? But these are lash extensions. They take these lashes and they glue them to the anatomic natural lash on the upper lid. They put these on about every 3 to 4 weeks because, as you can imagine, as our eyelashes grow, that lash grows with it, and they have to take them off and then reapply them closer to the base of the lash. So there's glue involved in that. There's solvents involved in that. That little tiny space between the anatomic lash and the fake lash is a nice breeding ground for Demodex, for bacteria, for lots of things. And that's often why you see inflammation like this. Redness equals inflammation. That's what we have to teach our patients. And so, like the questions we talked about just now, how do you clean your extensions? How often do you take breaks from them? Those are good things. Sometimes patients will not give these up, but we can at least educate around them. And as these have grown in popularity, they typically sometimes will avoid cleaning them because they're afraid that they're going to mess with the glue. But one really easy way that you and I can help our patients is by prescribing hypochlorous spray. So do that twice a day. and use a lash brush to actually like get in there and mechanically remove some things. That keeps the lashes clean, and it actually will help their extensions last longer. So hypochlorous spray is one of those easy ways to help our patients with eyelash extensions when they won't give them up. Often they will cause itching, redness, like we've seen now twice in pictures, pain, heavy eyelids, because as you can imagine, that's heavy. They'll get lag ophthalmos at night. The glue, again, can cause contact dermatitis, allergic blepharitis, all kinds of things that can happen because often the glues will have formaldehyde in them. So they can actually visit with their person that's doing this and look at the ingredients of the glue. And then there's the mechanical consequences. So best practices are to investigate what's in the glue, use hypochlorous spray to help clean them, and take breaks in between fills. Don't just continue. I had a patient recently and she'd had them on for 4 years, not the same pair, but she just kept doing it because, and she's like, it was really dumb. I did it for my son's wedding and then I just got in the habit and I just never stopped. And so we talked about that. And so she's like, you know what, you're right. I need to take a break. I just needed someone else to say that to me. So what do we see here? False lashes. What do you notice on that lower eyelid? And of course you can see the upper eyeliner. So now we know what mascara looks like. We know that those are extensions, or maybe they're glued false eyelashes. My suspicion is they're extensions. I can't really tell unless I have her look down and pull that lid up, right? So looking at eyeliner, the top one I'm actually okay with, but when you start putting liner right on top of the meibomian glands, which is what people call tight lining or putting liner on the waterline, see how it's like all caked up there in the corner and all across her meibomian glands? That's always a big no, but that's eyeliner. That's what they're doing there. So another best practice, you don't do that. And looking at ingredients is a big piece here, but the main thing here is actually the physical presence of something blocking the meibomian glands. One thing that I talk to about every single patient about is sunscreen. It's so important, and our patients do not put sunscreen on their eyelids, and they can't put sunscreen on the inside of their eyelid, which gets exposed. So we have to talk about sunscreen, and we have to talk about ophthalmic sun lenses, because the eyelids are the most common place on the body to get skin cancer. The skin there is 0.5 millimeter thinner than anywhere else on the body. It's subject to more sun damage because people don't protect it in the right way. This is an easy way to help patients not only prevent cataracts and macular degeneration, but also skin cancer and the aging process around the eyes that already age faster than anything else on the body. So that's a great one. And I literally just do it behind the slit lamp every time. I tell the patient what I'm doing. I'm looking for lumps or bumps because this is the most common place to get skin cancer. And every single patient sits back from the slit lamp and they're like, what are you talking about? And I walk them through why, and they're like, oh my goodness, you're right. I don't do that. And I will start doing that. So watch your sunglass sales go up and your optical when you start having those conversations. And we carry sunscreen. That's important. And so they wind up with sunglasses and sunscreen on the way out, especially this time of year. So what do we see here? What's a great question that we can ask a patient who maybe looks like this? So one of the questions is, which brand of sunscreen do I recommend? So I carry 2. I have no financial pieces with either one of these. Epionce is one. It's SPF 50. And the other one is Ulta MD. And depending on which sunscreen you're using, it can be anywhere from SPF 42 to 47, I think. They have like 6 or 7 different sunscreens, but both of those brands are great. So you're right, Miss Lauren, this patient is, my question to her would be, what are you putting on your lashes, right? Because what do you see? You can tell that she's used some kind of lash serum because of all of that hyperemia and right at the base of the lashes. And you can just tell. I mean, we see patients on a prostaglandin analog with our glaucoma patients all the time. We know. I had a 13-year-old a couple of weeks ago that I saw, and with her mom, of course, and I looked at her and I was like, and she didn't have any makeup on or anything, but I asked her, I was like, your eyelashes are really long and they're really pretty. Do you put something on them to make them that way, or are they naturally like that? And she's like, oh, I started using this tube of stuff that my friend gave me. And I asked her what the name of it was, and she told me, and I was like, okay, so that has this ingredient in it, and it's can cause these things. And her mom had no idea she even had it. So let's just talk about that. But you can't ever start too early, because this was a 13-year-old. What do we know about lash serum? So Latisse is the only FDA approved lash serum. The active ingredient, of course, is bimatoprost 0.03%. But there's all of these synthetic prostaglandins that are over the counter. And because they're this synthetic, they don't have to go through the FDA approval. They don't have to have a prescription. So patients can buy these anywhere. And when you look at the ingredient, they'll have isopropyl cloprostinate or some kind of like prostinate in the name. And super important to know this, because you and I both know that this can cause meibomian gland dysfunction, dry eye disease, ptosis, periorbital fat atrophy, involution of dermatochalasis because of that. All of these things, we don't want our 13-year-olds and really anybody on these kinds of things unknowingly, right? And so that's super important to be able to ask those questions and show that to patients and say, listen, here's what's really happening, okay? Blepharopigmentation is a big one. And unfortunately, when we see this, it's too late because they've already done it to themselves. And every time that little tattoo needle goes through the lid, it typically punches the meibomian gland and destroys it. And my worst dry eye patients are the ones that have had this done. When they were trying to streamline their morning routine or help themselves in some way, and they wind up inadvertently causing themselves a lifetime of complications. So if patients ask about this, this is always an absolutely no, we are not doing this because it can cause so many problems. So toxins in cosmetics, and this is in your handout too. So this is what I just hand to patients. And that way they can actually go and do their own research. They can use an app like Think Dirty, or the other one is EWG. That's a really good app too, because they can just shoot the QR code on their product and it will say what's in there that maybe that needs to be flagged. So these are things that we can send with our patients that we're not having to do in the lane with them in that moment, because we're all pressed for time. So hopefully you guys can utilize that as a resource. Another fantastic resource that I'm really excited about, and you guys are certainly going to be one of the first to hear about this as far as the publication. So I was fortunate enough to work on the latest TFOS workshop, which was the lifestyle workshop. And I was on the subcommittee for cosmetics. And this is going to be published in the next 30 days. So you'll have access to this guide and this resource on the impact of cosmetics on the ocular surface. So I'm super excited to share that with you. And I'm hoping that that's going to be a resource that you can utilize, you can share with your patients, you can share with your team, and be able to help our patients in a broader way, and to generate knowledge around cosmetics and help the public understand what's happening too. So in summary for this section, lid and lash strategy, good things. And this is what I talk about with visual hygiene. Heat therapy for a full 10 minutes, the 20-20-20 rule. Make sure that you're washing your lids and lashes every night and morning, and discuss best cosmetic practices. An easy one is utilizing hypochlorous spray morning and night to reduce that bacterial load, and especially with extensions. And then have a vetted sunscreen and serum that you can talk to patients about when they ask, right? So you can do some research there. So just to touch on, we've talked about hypochlorous spray and why that is important, but let's just remind ourselves what it does. It's an antimicrobial, so it's a broad spectrum microbial kill. Its onset of activity is quick, so 1 to 2 minutes, and versus betadine. And it remains active with a toxicity level 1,000 times lower than betadine. If you've ever done a betadine wash on somebody for viral conjunctivitis, you know that they sometimes wish they could just move on with their EKC versus the betadine wash, because it does not feel good, right? We see our patients all the time that have, betadine on the front surface because they're having injections, whether it's AMD or diabetic macular edema, and it covers some bacterial strains missed by betadine. So it's a great antimicrobial, and because of that, we have these anti-inflammatory effects because it neutralizes bacteria and their toxins that cause inflammation. So again, this is a great way to help our patients that are doing things that maybe we don't agree with, but it can be a best practice to help them through that. So let's switch gears and spend the last half of our talk about dry eye and about how all of the things that we can do to help our patients. So the three things that we need symptoms, and I like to utilize a speed score that is handed to every single patient that's there for their comprehensive exam, and it's given to every patient on their dry eye follow-ups so that we can ascertain symptoms that patients might not tell us. Once we have symptoms, every single patient, I do vital dye. So I'm doing fluorescein strips, and then I'm just pushing on glands. It can be as simple as that. You can diagnose every single patient with dry eye disease with those three things. No special equipment. All it's going to take is your mindset and your consistency. People in your team to help you do that. So let's talk about beyond that. In our clinic, because we've been doing this a long time, we do point of care testing. And so we measure tear osmolarity. Why does that matter? Because remember, when you have a hyperosmolar state on the front surface, corneal epithelial cells are dying. So I need to know where we are in this chemistry of our tears on the front surface and if we've lost homeostasis. So when we have a patient that has a speed score of greater than 6, we have standing orders to do point of care testing with tear osmolarity and MMP9. Remember, that's a non-specific inflammatory marker that can be present in patients who have dry eye disease. It can also happen when they have allergic conjunctivitis or conjunctivochalasis. So it sometimes is really helpful when they have a normal tear osmolarity and they have a positive MMP9, you don't have dry eye disease, you have a different issue over here. So it tells me information in the absence of information, if you will. So I do point of care testing often. We just talked about osmolarity, so for the sake of time, I'm not going to spend a ton of time there. Tear quantity, so you can look at tear meniscus height as you're doing your vital dye. Once you get where you see normal, you will know what abnormal looks like. Can you measure this non-invasively? Absolutely. But you don't need any special equipment. You can just use your vital dye to do that. Lid structure and function. Meibography is fantastic. I use it every day, almost on every patient, but it only tells us where we've been in time. It doesn't tell us what's happening right now. So I often will use it for education and patient awareness, but I don't use it for functionality. What do we use for function? I have to push on those glands to see what's happening functionally. Do the glands work? What's the expressibility of the gland? And what does it look like? Is it clear? Is it toothpaste? Is it cloudy? Somewhere in between? All of those things I need to know, because if I can address function before it affects structure, that is absolutely our goal. And remember that survey that we saw at the front, people are having changes in their teens and 20s with their meibomian glands. And then lo and behold, we get things happening all these years later. We have got to be diligent about looking for this and educating around it so that patients can have best practices and we can intervene early. Obviously, this is a cornea that's got corneal staining. I love to use a Ratten filter whenever I'm behind the slit lamp because it fluoresces that dye beautifully, lights up like a Christmas tree. It's just that much easier to see. So that's why I shared that in here. This is from TFOS DUCE 2. These are the steps in managing dry eye disease. So this is a big document, right? And so this can help us identify what we should be doing with our patients. And so do I follow this exactly? Not always, but it certainly gives us a great guideline. And for the most part, I do follow it. But, step 1 is about education. And then step 2, we're going to talk more about. One of those is IPL in here, but prescription therapeutics. We have things to help our patients. It's just knowing when to employ them. So what I'm going to go through is actually in alphabetical order on how we can help our patients. So I don't even like to say artificial tears, but because that's the word that most people use, I have it in here like that. Artificial tears is really not a good name. It's a lubricating drop. There's nothing artificial about a patient's tear. There's over 1,500 different proteins and lipases and things that you and I can never artificially recreate. So while it's a lubricating drop that can help support the front surface, that's what it does. And that's how I describe it to patients. So I will absolutely use this in conjunction with therapy, but I never use this as therapy alone. I look for formulations that are preservative free. I look for formulations that have HA, and I look for formulations that have trehalose in them, because that combination can certainly help and be adjunctive to what we're doing therapeutically. Amniotic membranes. So these are available cryopreserved or dehydrated. They act as therapeutic bandages, basically. So I will use these, especially in a patient that has neurotrophic keratitis, which at stage 1 looks exactly like dry eye disease. The only way that you're going to know that it's dry eye versus NK is to do corneal testing and test their sensitivity. So if you have a cornea that looks like this one that we just saw, and their speed questionnaire or their questions are, no, my eyes feel great, that means that you need to do sensitivity testing, because there's no way that cornea should feel great, right? But I often will use amniotic membranes when I have corneal staining like that, and when I have a patient that has neurotrophic keratitis, because I'm going to wind up ordering something therapeutically that might take a few weeks to get. But you can use them too for, a corneal abrasion. It works beautifully in that. There's multiple reasons to use these, and I will typically put one on, like I had a patient last week, I put it on Tuesday and I took it off on Monday. I always cover with an antibiotic while they have it on, and you can not use it for that long. You can use it 3 days, but typically most people use them 5 to 7 days. Autologous serum is when you take the patient's own blood and you remove the red blood cells and the clotting factors. Now we have all those growth factors and nutrients normally found in a normal healthy tear. And so this is a great way to also treat patients with neurotrophic keratitis and with dry eye disease. And so I will often use this. I usually start reconstituting at 40%. I have a local lab that does this for me. There's a national company that you can utilize, but I like the local lab because they can draw the blood and they can make it right there. Some optometrists do this in their office. If you've got a phlebotomist, or if you're the one drawing blood and you've got a centrifuge, you can absolutely do it too. But I often will use this in my patients that are at a level 3 to 4. We'll talk about levels here shortly. Cyclosporine. So this came out commercially available in 2003. Remembering that it blocks T cell activation. So the most recent formulation is a calcineurin inhibitor. Remember, T cells contain that. So we're blocking one part of that inflammatory cascade. And this is what patients need, whether it's this or lifitegrast. They need something on that front surface to help treat inflammation long term. I use steroids all the time, but I can't use them long term, right? I use them for flares. I use them to get patients started, but I need an exit strategy. And so cyclosporine and lifitegrast both are ways that I do that. And lifitegrast works in a little different pathway of inflammation, but both clinically relevant, used in patients all the time. We have these tools. Neurostimulation, there's 2 ways to do this. We can do it drop-free, drug-free with a mechanical device called iTear 100. It's the only one that's commercially available on the market. Or we can do varenicline, and that's the chemical version of neurostimulation. The benefit of this is you're doing something through the nose. Remember the lacrimal functional unit. You have that little tiny nerve, that afferent ancillary portion of the ethmoidal nerve that lives there, that's part of the trigeminal nerve, that controls 34% of our basal tear layer just by breathing in and out. When you stimulate that nerve, you stimulate the entire lacrimal functional unit. So when you do that, you're getting the lacrimal glands to produce, you're getting the goblet cells to degranulate, and you're making the meibomian glands actually express. And so when you trigger the lacrimal functional unit, you're doing all of those things, and you're creating basically what I call the patient's tears on demand. It's their tears, all of those 1,500 different components, that natural tear that we so desperately want the body to make, we're making it happen by activating this. So I use NeuroStim all the time. Especially, if you want ocular sparing, if you've got patients on glaucoma medications, you've got patients that are doing procedures, you have patients that wear makeup and they don't want to mess that up by putting drops in, this is a beautiful way to do it. So topical corticosteroids, of course, quell ocular inflammation. So for these patients, if I have corneal staining, I will often use a steroid right alongside lifitegrast and cyclosporine. I'll start them in like inductive therapy together. They stay on the steroid for the first 4 weeks. When they come back at week 4, we'll drop the steroid, continue with their long-term therapy. That's how I incorporate that. Low-level light therapy or photobiomodulation is making its way into our clinics. And the nice thing about this is you can treat all skin types. And with that photobiomodulation, we're still learning a lot here. And so there's not a ton of information out there, but I've got a couple of resources there for you. But people will use this in conjunction with IPL, as well as just utilizing it with other methodologies like heat and expression. So more to come, but certainly this is making waves into our space. IPL I've been doing for the last, 6 or 7 years. It works beautifully for telangiectatic vessels, ocular rosacea, and subsequent meibomian gland dysfunction from that. We can only use it on patient skin types 1 through 3 safely. You can use it on some 4s, but we got to test it and make sure we're using the proper settings. And I like to test patients for 72 hours, let it set, and then come back and relook at it. It's an easy procedure to perform in the office. You just need to make sure you've got laser grade corneal shields, IPL grade corneal shields in place, or adhesive to make sure you're keeping the patient safe. But the way that it works with IPL, and I love this illustration, it's targeting blood vessels and it also targets pigment. But for our talk tonight, we're targeting blood vessels. And you can see when that light absorption happens, it's selective photothermolysis. So it's selectively utilizing a certain wavelength of light, photo, and then we're lysing the oxyhemoglobin and therefore the blood vessel. We're basically reducing that. So that's what you see in that picture. The skin stays intact, but the blood vessel gets destroyed. And we'll watch it again in this video. When you have that correct wavelength of light, everything else stays in place that we want to. Here's a great example of a before and after, and those little telangiectatic vessels just disappear. Same thing here, just clearer skin. This is a patient that has dry eye for many years. Super happy with the results. You can also treat chalazia with it. So if you don't want to do INCs, and I can in Oklahoma, but I rarely do now because I have this option and patients want an injection-free, scar-free, blade-free management. So often this is our first line and it works really well. Patients are really happy with this. Here's a patient he popped up with that and one treatment and the next day it looked like that. I will tell you that is not normal. This is more normal where you do multiple treatments to get where you want to go, but it can happen if you can get there fast enough. The problem is most of our patients let it go and it's more chronic, but you can still tackle it. And the way that IPL works, and I like this methodology of thinking about this paper that was published back in 2017, what causes meibomian gland dysfunction? So this group came together and said 6 things: bugs, enzymes, inflammation, stasis, temperature, and obstruction. So when I go through my assessment and my plan, I address these things because there's multiple ways to get there. You can treat bugs and enzymes and inflammation and stasis and obstruction with IPL. You can treat bacterial load with hypochlorous spray, and you can treat enzymes and inflammation with lifitegrast, and then maybe you add an omega-3 with that. So there's multiple ways to get here, We have a new medication that hopefully will get approved for Demodex blepharitis TP03. Their PDUFA date is in September. So stay tuned for that, because that's the first time we're going to have a product that actually will eradicate mites. Now, will it come back? It's a chronic disease, right? But when you look at the data, patients are on a drop twice a day for 6 weeks, had complete mite eradication, and up to a year, I think almost 60 to 80% were still clear at a year. So it might be something that we pulse. We don't know yet because we've only seen the clinical data. We don't have clinical experience with it, but stay tuned. Lots to be excited about there. Punctal plugs still have a role. I absolutely still do punctal plugs. I wait until I make sure we have no inflammation. The inflammation's been treated, and I only do plugs that dissolve over a longer period of time. I don't use silicone plugs anymore because of extrusion and biofilm issues. Scleral lenses can absolutely help patients symptomatically. It's not going to help the disease process itself, but can it give patients comfort and vision? Absolutely. And Dr. Wu could talk for days about this, but we often will fit scleral lenses for patients that really struggle to maintain that pristine ocular surface or even a functional ocular surface. Supplements are one of those level 1 things that I talk to every single patient about. We need those omega fatty acids, and we need that correct ratio of DHA and EPA. These aren't regulated, so you have to do your research, but you need the correct ratio. And the one that I use has GLA in it as well, because that tackles a different part of the arachidonic acid pathway. So make sure that you've got this research that you can give that to patients. Thermal pulsation or heat and expression, we have to do something to unblock the glands. So I couple this with IPL. So IPL series, and then we're going right back behind it and doing either thermal pulsation or heat and expression. There's multiple things on the market, but that's what I call interventional dry eye. We're doing procedures to intervene, and with great success. So a beginning dry eye clinic, we talked about having a questionnaire, vital dye, gland function. Those 3 things, along with your mindset, and you are off to the races. And you've got all of these therapeutic medications at your disposal that you can write prescriptions for. You can absolutely have a supplement. And then good lid hygiene, like we talked about in the first half of this hour, making sure that patients understand their beauty habits, the cosmetics that they use, and what detrimental effects those can have, and best practices around those. And then, this is just me. This is not set in stone. An intermediate dry eye clinic, you gain success with that. You get really comfortable, and then you add some in-office procedures. Maybe you add mybography to help educate, and then you just continue to build on that, right? None of us start here overnight. This is where I am now, but none of us start here. We start with good questions, gland secretion, and vital dye. So I put this in here just so you guys have this, but my partner and I want to make sure that we are managing patients in the same way. So that's why this is so detailed, because we're both doing the same thing. We're adding our own authenticity and our own way of doing it, but what we're doing is exactly the same. So the patients have the same experience throughout our whole practice. And then stage 2, stage 3, and then the stage 4, which is where we hope patients never get to, because we're trying to just keep them functional at this point. And I have far too many patients here. And my question to myself is always like, gosh, I wish I had seen this patient 5, 10, 15, 20 years ago. What could we have done differently if this person, knew this? So we just keep building and layering, right? And adding to these things. Hang on, I'm going to get rid of my Q&A for just a second. Okay, so ultimately, our actions should treat inflammation, right? And we have to treat obstruction. And all of these outside things, remember that desiccating stress, like we talked about, can be lashes, can be mascara, can be a new makeup, can be tight lining and that eyeliner rubbed all over the meibomian glands. And it can also be Demodex and bacteria, as well as, hormone changes, contact lenses, birthdays, All of those things can cause desiccating stress. So it's a multifactorial disease. We have to do a multifactorial approach. And the exciting thing is we have at least, let's see, 1, 2, 3. We have 3 medications that I know of right now with with PDUFA dates coming up specifically for dry eye. One hopefully will have something related to meibomian gland dysfunction that's actually a drop. One is a completely unique molecule and it's a RASP inhibitor, and it actually will target dry eye disease and allergic conjunctivitis. And remember that about 18% of patients have both at the same time. So that's exciting. And then we talked about TP-03. There are lots of other things right behind it. There's 3 or 4 more things in the pipeline. There's a keralytic that's an ointment that can help with that keratization. So lots of reasons to be in this space and to be excited. And to do all of these things, we need a great team around us. So rely and teach and bring those people along with you, your technicians, your ocular hygienist, your dry eye coordinator. Sometimes that's all the same person, right? But bring them along with you, teach them the why, let them help you lift this.